When you break your arm, the diagnostic process is, well, it's almost comforting in its clarity.
Oh, absolutely. It's a completely binary situation.
Right. You go to the hospital, the doctor takes an x-ray, and there it is, just a jagged white line on a black screen. They can point to it and mathematically prove that something is broken.
But that raises the big question, right? What happens when that x-ray is entirely blank, but the patient sitting on the exam table is still in profound pain?
Exactly. And welcome to today's deep dive. It is Tuesday, June 30th, 2026, and today we're looking at a medical mystery that affects millions of women. We are trying to figure out how we actually measure improvement. Like, how do we mathematically prove a treatment worked when the condition itself is practically invisible to standard scans?
It is honestly one of the most challenging frontiers in modern medicine right now.
Yeah.
And to really explore it, we're using a very specific medical lens today. We are looking at women's pelvic floor health, specifically two widespread conditions, genitourinary syndrome of menopause and vaginal laxity.
And the numbers on these two conditions are just staggering. I mean, we're looking at data showing up to 80% of postmenopausal women report troublesome symptoms from genitourinary syndrome of menopause. 80%.
It's massive.
It is. And then if you look at plastic surgery clinics, 1 in 6 women walking through the doors report vaginal laxity. Yet, despite being literally everywhere, these conditions remain vastly underreported.
Yeah, there's this heavy shroud of embarrassment. Or, worse, this totally dismissive cultural belief that it's just normal aging and you simply have to put up with the discomfort.
Which is incredibly frustrating.
It's a tragic misconception, really, because the physiological changes happening here are profound.
Yeah.
They are measurable, even if they don't show up on a standard bone x-ray. I mean, genitourinary syndrome of menopause, it's an umbrella term for what happens when a woman's estrogen levels drop.
So what exactly happens physiologically when that estrogen disappears?
Well, the body stops producing glycogen in the vaginal tissue. And that alters the local microbiome, the pH levels rise, and the epithelial tissue itself physically thins out.
Wow.
Yeah, it literally loses its vascularization, meaning blood flow drops, and that natural elasticity just disappears.
So it's definitely not just a vague feeling of discomfort then. The tissue is changing its physical structure.
Precisely, causing severe dryness, burning, and just significant pain. And then vaginal laxity, on the other hand, that's generally driven by the physical trauma of childbirth. The levator antemuscle stretch and the microscopic collagen matrix in the vaginal wall gets altered.
Which leads to that physical sensation of looseness.
Exactly.
And because millions of women are desperate for relief from these structural changes, the medical market is flooded with interventions, right? I mean, we're talking about everything from localized hormone creams to incredibly expensive energy-based devices.
Oh, like the fractional lasers and radiofrequency wands. They're heavily marketed right now.
They really are. Which brings us to the core mission of today's deep dive. We aren't just here to read you a brochure for a new medical device. We're diving into the hard clinical research to answer the ultimate question for you. What counts as a meaningful improvement after these treatments?
Because that is the real issue.
Right. If a company says their fancy new laser improves tissue health by 20%, does that actually matter if you still feel terrible? Is improvement just a statistical blip on a chart, or is it something you actually feel in your day-to-day life? Okay, let's unpack this.
To really understand how modern medicine is attempting to measure that subjective feeling, we have to look at the gap between a result being statistically significant in a lab and something being clinically meaningful to a real human being.
There's a big difference between those two things.
A massive difference. And researchers bridge this gap using a critical concept. It's known as the MCID.
The minimal, clinically important difference.
That's the one. So in the research world, doctors use complex questionnaires to track symptoms. The MCID is the absolute minimal change in a patient-reported outcome measure, or PROM, that is actually meaningful and noticeable to patients in their daily lives.
I think the best way to visualize this concept is think about turning up the volume dial on your TV.
Oh, I like that analogy.
Right. Let's say you're sitting on the couch and you turn the volume up from level 10 to 10.1. If you place a highly sensitive laboratory-grade decibel meter right next to the speaker, it will register that the TV is technically louder.
Which is your statistical significance.
Exactly. The data proves it changed. But if you, sitting all the way back on your couch, cannot literally hear any difference in the dialogue, then that technical change doesn't matter to you at all. It lacks clinical relevance.
Right, because you still can't hear the show.
Exactly. The MCID is the exact threshold on that dial where you finally lean back and say, yes, I can actually hear the TV better now. But here is my pushback. The TV dial analogy only works if we know how the volume is calculated in the first place.
Because a TV has a literal mechanical knob.
Yes. So, how do doctors actually calculate this volume dial for something as deeply personal and subjective as vaginal health?
Well, they essentially map complex math directly onto a simple human feeling. There's a really fascinating study from Amsterdam UMC that shows perfectly how this works in practice.
Oh, what did they do?
The researchers looked at the PISQIR. That stands for the Pelvic Organ Prolapse Urinary Incontinence Sexual Questionnaire, IUGA revised. It's a major tool that measures sexual functioning.
Okay, so a very detailed survey.
Very detailed. And for sexually active women who had surgery for a symptomatic prolapse, the researchers wanted to find that exact minimal difference. They determined that the MCID was exactly 0.31 points on the summary score.
Wait, 0.31 points? That sounds like an incredibly tiny fraction.
It sounds microscopic, right? But it's actually the exact tipping point. The crucial takeaway here for anyone listening, the real so what of this, is that any study boasting a statistically significant surgical improvement of less than 0.31 points should be viewed with extreme caution.
Because even if a shiny new surgical device creates a microscopic change, it overestimates the real-world clinical relevance to the patient.
Exactly. The patient won't actually feel any better.
Here's where it gets really interesting. If 0.31 is the magic number for that specific surgery questionnaire, how do we measure the baseline symptoms of genitourinary syndrome of menopause and vaginal laxity? Because laxity is defined simply as the feeling of looseness, which sounds entirely subjective.
It does sound entirely subjective.
So can a subjective feeling really replace a physical diagnostic machine?
It absolutely can. Doctors use a specific tool called the Vaginal Laxity Questionnaire, or VLQ. It's a validated 7-point scale, and despite being based just on subjective perception, research shows this patient-reported tool is highly reliable.
Really? Just the questionnaire?
Yeah. It's often sufficient to confirm laxity even when compared to physical devices like peroneometers. The patient's personal perception is remarkably accurate.
That is incredibly validating, just acknowledging that the patient's perception is the physical reality.
It really is. But the laxity questionnaire is just one piece. When you read through the clinical trials for all these treatments, they almost universally rely on two major scorecards to measure improvement. The big two, as we can call them.
Okay, lay them out for us.
The first one is the Female Sexual Function Index, or FSFI. This is a 19-item questionnaire covering everything: desire, arousal, lubrication, orgasm, satisfaction, and pain.
Wow, it leaves no stone unturned. What's the scoring system for that?
The maximum score is a 36, but the critical number is 26.55. A score of 26.55 or less equals clinical dysfunction.
Got it. So that's the subjective patient-reported side. What's the second scorecard?
The Vaginal Health Index, or VHI. This one is a physical assessment done by the doctor. They check elasticity, fluid pH, epithelial integrity, and moisture. They score it from 5 to 25.
And what's the red line for that one?
A score of 15 or below indicates vaginal atrophy.
Okay, so we have our two rulers now, the FSFI out of 36 and the VHI out of 25. Tying this back to our MCID concept, what counts as a meaningful improvement on these?
What's fascinating here is that a meaningful improvement, the MCID for the FSFI in these treatments, is generally considered to be a jump of about 4 to 5 points.
So if you start at a 12, going to a 13 isn't enough. You need that 4 to 5 point leap to really feel the difference.
Exactly. You need to clear that hurdle.
Okay, rulers established, threshold set. Let's put these heavily marketed energy devices to the ultimate test. What actually happens when we compare real treatments against a sham, like a placebo?
This is where we separate the hype from the rigorous science. Let's look at radiofrequency first. There was a single-blind, randomized trial on non-AVLED capacitive resistive monopolar radiofrequency, or CRMRF.
That is a mouthful. Basically using controlled radio waves to heat the tissue from the inside out, like a microwave gently warming the submucosal layers to wake up collagen production.
That's a great way to picture it. And the results of this trial were undeniable. The treatment group's FSFI jumped 5.86 points.
Oh, wow. So they easily cleared that 4 to 5 point MCID threshold.
They shattered it. And it wasn't just the subjective scores. Their VHI increased by 4.75 points.
Which means the actual tissue improved physically.
Yes. It shifted many of the women from atrophic to non-atrophic, meaning their scores moved above that critical 15-point line. Meanwhile, the sham group saw no meaningful change at all.
So radiofrequency clearly works beyond just a placebo effect. But wait, I have to push back here because what about the JAMA study on fractional CO2 lasers?
Ah, the JAMA study.
Right, because that made massive headlines. In a trial comparing actual laser therapy to a sham low-energy laser, they found that both groups improved after 12 months. But the laser group did not beat the sham group by a margin that met the minimal clinically important difference.
That's correct. It essentially failed the MCID test against a placebo at that 12-month mark.
So does that mean the whole laser industry is just selling a placebo effect?
Well, we have to look at this impartially, because while the JAMA study and even some Guardian reports suggest laser improvements might be a placebo effect, you have to weigh that against other massive data pools.
Like what?
It's like a massive NICU overview. They analyzed 542 patients, and they showed a statistically significant improvement in vaginal health index, scores an incredible 10.7-point jump, and huge FSFI improvements for lasers at a 1-month follow-up.
A 10.7-point jump is huge, so how do we reconcile that? Lasers fail against a sham at 12 months, but cause massive tissue improvement at 1 month.
This raises an important question about how we interpret conflicting data. The time frame changes everything. At 1 month, the tissue is clearly healing from the laser. But at 12 months, the sham group might naturally improve just from pelvic floor awareness, while the laser's effects might naturally fade.
Ah, I see. So the lines blur over a year.
Exactly. Looking at the MCID across multiple time frames, like 1 month versus 12 months, is absolutely crucial for understanding true efficacy.
That makes total sense. But let's take this even further. Let's say we have two treatments. They both cross the MCID threshold. They both improve the numbers. How do we decide which one is actually a better improvement?
That is a great question. And there's a retrospective study published in MDPI that set up a comparative analysis for exactly this. They compared diode laser and monopolar radiofrequency for GSM.
A head-to-head matchup. What did the data show?
The data showed that both modalities worked beautifully on paper. The diode laser raised the FSFI from 11.0 to 15.3.
A 4.3-point jump right in that sweet spot.
Yep. And the radiofrequency raised it from 8.9 to 14.3, a 5.4-point jump. Both also raised the VHI score similarly, taking them from around a 13 to a 16.
So what does this all mean? The numbers are practically tied. What counts as the tiebreaker for meaningful improvement here?
The tiebreaker is the patient's actual experience getting there. The researchers used two new metrics. First, the patient global impression of improvement, or PGII, and second, the visual analog scale, the VAS, for procedural discomfort.
Okay, so factoring in the pain of the procedure itself.
Exactly. And while the clinical efficacy was the same, the radiofrequency had significantly lower procedural discomfort. The VAS was 14.1 for RF compared to 53.6 for the laser.
Wow. 14.1 versus 53.6. That is a radically different experience for the patient.
It's night and day. And because of that pain difference, a much higher proportion of RF patients, 95.5% compared to 74.3%, for the laser-reported high global impression of improvement scores.
Even though the clinical lab numbers were basically identical, that really is the ultimate takeaway here. Meaningful improvement isn't just about restoring tissue or hitting a 4-point jump on a sexual function index.
No, it's not.
It's about the patient's experience getting there. A highly effective treatment that causes significant discomfort during the procedure may actually be considered a less meaningful overall improvement by the patient than a gentle one with the exact same physiological outcome.
Because the journey colors the destination.
Let's quickly summarize this whole journey we've been on today. We've learned that measuring medical success isn't just about achieving statistical significance in a lab.
Right. It requires hitting that minimal, clinically important difference.
Exactly. Utilizing validated tools like the FSFI and VHI, proving efficacy against a sham over the right time frames, and crucially, factoring in the patient's actual comfort and holistic experience.
And for everyone listening, I think the most important thing to remember is that your subjective experience, how you actually feel, is a mathematically validated part of modern medicine. It's not just in your head.
Which leaves us with this final thought to mull over. If the definition of a successful medical treatment inherently relies on a patient's subjective feeling of improvement, their literal impression of the outcome, does that mean the ultimate authority in medical science isn't actually the data on the doctor's clipboard, but the perception in the patient's mind? Keep diving deep, and we'll catch you next time.